Okay, so this afternoon, I'm going to spend some time sharing with you all about advancing health equity as a core system value. We'll start with reviewing some definitions related to health inequities and the social determinants of health. And then we'll proceed with a brief demonstration of how health inequities and social determinants of health impact health outcomes here in the state of Florida. We'll move forward with reviewing the Cooperative Extension National Framework for Health Equity and Well-being. And then we will finish up by looking at an example from one of my programs, which is the Rural Health Program. But this program has been around since 2017, and we focus on reducing rural and racial inequities in Florida. So let's start by looking at the definition for health inequities and how they contribute to health disparities. So health inequities are avoidable systematic differences in the health status or either the distribution of health resources by different population groups that impact the ability to achieve optimal health. So then health equity is everyone having a fair and just opportunity to achieve optimal health. And so when those inequities are in place, they contribute to health disparities, which are simply differences in health outcomes among specific population groups. So these could be by race or ethnicity. It could be by socioeconomic status. So that is education, income, and work or occupation. It could be by gender or sex, age, religion, and geographic location, among many others. Structural inequities drive the unfair distribution of resources. And so that is what ultimately contributes to social determinants of health. So the structural inequities include personal, interpersonal, institution, and systemic factors that we'll dig a little bit deeper into in just a moment, but they contribute to disadvantage of social groups within populations. And so these drivers are mainly experienced as in the form of discrimination. So it could be racism, sexism, classism, ableism, among others. So looking a little bit deeper into the structural inequities that drive these unfair distributions of resources, we can see that there are many levels by which the social determinants of health operate. So for the intrapersonal level or individual level, these mechanisms are individual knowledge, attitudes, beliefs, and skills. At the interpersonal level, they're families, friends, and social networks. At the institutional level, there are organizations and social institutions. And at the community level, there are relationships among those organizations. At the systemic level, the mechanisms are national, state, and local policies. They can also include laws and regulations. So I will provide just probably one example from each of these levels. So if you think about the intrapersonal level, stereotype threat is one of the factors at the intrapersonal level that could impact health outcomes. And stereotype threat is the fear or anxiety of confirming a negative stereotype about a person's or an individual social group. For example, women are bad at math. That might be a stereotype threat that women might experience related to STEM education, for example. Implicit bias is an example of an interpersonal level factor. And so we see this quite often when people do not have a neutral stance, but instead they have a preference for a person or a group of people. And so that's why we use the term implicit, because it might not be a conscious sort of understanding. And we see this a lot. People have studied this with regards to research related to physicians, employers. And so those types of interpersonal or social interactions can impact health outcomes or other equitable sorts of outcomes. At the institutional level, we think about hiring and promotion practices or under or over valuation of contributions. And so those are things within organizations that can impact the outcome of individuals who experience those. At the community level, racially or class segregated schools. So you see a lot of schools that are segregated by socioeconomic status. And that has to do with, historical reasons, and we'll get into those as well. So even though some of the segregation that we might see in neighborhoods are due to personal preferences, they are often related to those interpersonal sort of relationships. And so we see that an interaction can occur across multiple levels of this system. So it's not just the interaction at one level. These institutional or community level factors can trickle down to impact interpersonal relationships and vice versa. And then finally, at the systemic level, you see different policies that have impacted outcomes. And so again, residential segregation has its roots there, and it remains a root cause of racial health disparities even until today. So the issue is that these structural inequities manifest as social determinants or determinants of health. And so these inequities produce systematic disadvantages that lead to inequitable social, economic, environmental, and cultural experiences that ultimately shape health outcomes. So for example, the impact of interpersonal, institution, and systemic biases in policies and practices leads to the sorting of people, for instance, into resource-rich or resource-poor neighborhoods and K through 12 schools. So it really, a person's flexible resources, so to speak, really determines how they fare in life. And that ends up being a major determinant of health that is often based on race or socioeconomic status, because the quality of neighborhoods and schools then significantly shapes a person's life trajectory. So the health of adults and children are impacted because the neighborhood would determine whether they have access to resources such as healthy foods or physical activity opportunities. It'll also determine the quality of education that children might receive. And these all are factors that can lead to preventable differences in health metrics like life expectancy. There's research that indicates that a person's zip code is more important than their genetic code. And so we'll talk about that as we move into the demonstration of how health outcomes are associated with determinants of health. And so you see here, this map is of the county health rankings, which is put out each year. And get my mouse back over here. So in this map, you can see that the darker colors are associated with lower health outcome rankings. And then the lighter colors are associated with better or healthier health outcome rankings. And so the way that health outcome is measured here is through a combination of risk factors. But for health outcomes, they primarily look at life expectancy and quality of life. So here in Florida, the top 3 healthiest counties are St. John's, Collier, and Seminole. I also pulled a few of the middle rankings, so to speak, the ones, the mid-range counties, Pasco, Lafayette, and Gulf. And then the bottom 3 for the lowest health outcome rankings are Madison, Putnam, and Union. And so if you look at the map here, we're going to look at a map a little bit later that shows the rural counties in Florida. But for sure here, Madison, Union, Putnam, and Union are all rural counties. And so we'll see how geography sort of impacts health outcomes, because as we can imagine, there are limited access to resources and many other determinants that go into influencing those health outcomes. So in table 1, we see I pulled the life expectancy in each of these counties. And so we see here, St. John's, Collier, and Seminole, the life expectancy ranges from 81 to 86 years. Whereas at the in the lower ranking counties, Madison, Putnam, and Union, life expectancy ranges from 68 to 76 years. So there's a 14-year difference in life expectancy between Union and St. Johns County. So if you're born in St. Johns County, they're going to say, oh, your life expectancy is 82 years. If you're born in Union County, then your life expectancy is 68 years. Now, of course, I don't mean to minimize, because there are lots of other factors at play, but that's just a, big picture sort of outlook there for those particular counties. Premature deaths, and this is per 100,000. So you can see that Union County has a lot more premature deaths than St. Johns County. So in table 2, we take a look here at a social and economic determinant of health, which is education. So we can see that for St. Johns County, the percentage of residents who have a high school diploma or higher is 95%. And you can see that doesn't vary much here in these top 3 counties. So 87, 94, and 95. In the mid-range counties, you can see that range is from 75 to 90%. And then in the bottom 3 counties, ranging from 77 to 82%. But here's where you start to see the significant differences with regards to the percentage of those 25 and older with a bachelor's degree or higher. In Union, it's 9%, and in St. Johns County, it's 45%. So significant differences there between the highest ranked and the lowest ranked county with regards to education. In table 3, we take a look at income. The median household income ranges between $37,000 and $44,000 in the lower ranking counties, between $48,000 and $53,000 in the mid-ranked counties, and then between $67,000 and $82,000 in the higher ranked counties. You can also see here when we look at poverty that in St. Johns County, the poverty rate is much lower at 8% compared to Madison, Union, and Putnam, where it ranges between 21 and 24%. For home ownership, which is an environmental determinant, the owner-occupied housing rate in St. Johns County is 80%, and in Union County is 66%. The median value of owner-occupied homes ranges from $243,000 to $361,000 in the higher ranked counties. And then when you looked at the middle ranking counties, that ranges from $105,000 to $162,000. And then for the lowest ranking counties, it ranges from $89,000 to $118,000. Technology, which is also an environmental determinant. So we see here that the highest ranking counties in the highest ranking counties, between 93 and 95% of households have a computer, with 85 to 90% of those households having broadband internet access. Whereas when you look at the lowest ranking counties, the percentage of households with the computer drops or is significantly different, 70 to 81%. And then for broadband internet access ranges from 59 to 72% of households. So significant differences in social, economic, as well as environmental determinants for those county health rankings with relation to the county health rankings. So these social and economic factors, along with environmental factors, account for about 50% of health outcomes. So historically, when we focused on, how to impact health outcomes, how to improve health outcomes, we've had a chronic disease issue and an obesity issue in America for a while, but a lot of that early work focused on medical care, clinical care, as well as health behaviors, which does make up about 50% of health outcomes as well combined. But in order to truly advance health equity, in recent years, we've begun to focus more on these social, economic, and environmental factors. So we'll take a quick look at health behaviors and clinical factors, because I don't want to leave those out of the equation, because they do make up 50% of the health outcomes. So if we take a look at physical inactivity, then we see here that the physical inactivity rate is higher in these lower ranking counties. And we can also see, though, that access to exercise opportunities are limited in the lowest ranking counties. So it's not just about teaching people or educating people on the importance of being physically active. If there is no way or no space for them to be physically active in, then those individuals will still be limited with regards to being active. And there you can see how the determinant of health plays a role in that. Similarly, for clinical care, the percentage of uninsured adults, and you can see there's a wide range across the counties here, but then when you look at the ratio of primary care physicians, in St. John's is 1,000 to 1, but in Union is 3740 to 1. So again, access is an issue. So to summarize on the structural inequities and social determinants of health, what we know is that structural inequities limit the opportunities of many people to reach their optimal health. Community health is dependent upon those determinants of health. So we can see from those health outcomes that there are definitely some inequities present that are likely contributing to certain counties having better outcomes than others. The choices that we make are made within the context of where we live, learn, work, worship, play, and age. And those factors then contribute to our health outcomes. So advancing equity requires a shift in focus to providing the resources that people need to thrive. You can see in the image here, for many years, as I mentioned, we focused on equality. We felt if we give people the exact same resources, if we just educate them, then we can reduce these disparities. But what we're finding is that we need to meet people where they are. We need to be able to adjust what it is that we are doing, whether that's working in cooperative extension or some other government or public health agency. We need to meet people where they are in order to ensure that everyone has an opportunity for optimal health outcomes. So that leads me to the Cooperative Extension Framework for Health Equity and Well-Being, focused on advancing health equity as a core system value. So the cooperative extension system is comprised of extension services of the nation's land-grant universities. And so, with over 3,000 offices across the US, we really have a reach and an infrastructure like none other. The extension services of land-grant universities are members of a representative body that's called the Extension Committee on Organization and Policy, or ECOP for short. There was a health innovation task force that was formed in 2020 in order to update the 2014 Cooperative Extension National Framework for Health and Wellness. So that was around the time that Cooperative Extension decided, we've done so much in agriculture over, hundreds of years, and we see around us that there's a need for us to address health. And so Cooperative Extension invested many resources into creating health and wellness positions like mine. I was hired in 2016. And so they developed positions like that across the country at land-grant universities, because Cooperative Extension decided they were going to focus on health. So we worked on a health innovation task force to update that framework, and ECOP approved the updated version of the framework in July of 2021. And so this framework is meant to serve as a roadmap for the next 5 to 7 years for health extension. Here's a list of work group members. So you can see variety, diverse group from around the country. Dr. Mike Gutter and myself were on the workforce or in the work group to represent Florida. So what we know for sure is that in order to advance health equity, we must change our approach. So in the popular report that we published related to the framework, we noted that people make choices, and even though a lot of our energy has been directed to informing and influencing those choices, there has not been significant changes in health outcomes, and instead we've actually seen things get worse in some areas. So as a result, we have to change the way we think about it and remove that focus on personal responsibility. Is not to say that personal responsibility isn't important, but that high level focus on personal responsibility, as if good health is personal success and ill health is failing. So we asked ourselves, how can Cooperative Extension think differently about its health related work? And how can we work in new ways to ensure that all people have an opportunity to experience optimal health? And so out of that came this framework. So this is the new framework for health equity and well-being. And so in this outer ring, you see those root causes of structural inequity that we just reviewed. And then you can see here in the ring below it, these are norms, policies, and practices that influence these social determinants of health. And so what we tried to do here was include additional social determinants that we felt Cooperative Extension was positioned or is positioned to address throughout the country within our individual communities. So those include housing, income and wealth, education, public safety, health systems and services, physical environment, employment, the social environment, supportive infrastructure, and access to healthy foods. So this framework then incorporates 9 social determinants of health. And so Then when we get to the inner rings, we start to see, well, here is how cooperative extension can advance health equity, which is centered here in the model. So we can identify and address health inequities. And then we can work through two major streams of activity in order to do that. The first stream is promoting healthy behaviors through communication and education. And this can be focused on either the general population or groups experiencing inequities in health outcomes. So it's not that this model is limiting our work to health disparities populations, but we are centering our work there. The second stream is creating healthy communities through collective action. And so this might involve working with and through coalitions to create healthier communities. And the work of these coalitions many times focuses on addressing the social determinants of health and reducing any barriers that people might have to achieving optimal health. And so all of these things work together to improve population health and achieve health equity and health status. And over here to the left in the model, the fin, we often refer to this as the fish, but the fin here then lists 5 high-level recommendations that cooperative extension should implement in order to be effective in achieving these goals. And so the first one is promoting health equity as a core system-wide value. And the second one is integrating data science with resident voice. Third is support extension programs and professionals. Fourth, accomplish work through partnerships and coalitions. And then finally, use community development principles and practices. And so I think a link was provided to the full report, but these are the 5 high-level recommendations, and then there are various action items underneath if you all would like to explore those at some point. So the new Cooperative Extension Framework recommends advancing health equity as a core system-wide value in order to ensure that all people have fair and just opportunity to achieve their best health. And so this framework then highlights ways that cooperative extension resources can be utilized to advance population health. And those include identifying and addressing health inequities. So if we see health inequities, we should address health inequities. Promoting healthy behaviors through communication and education, and then creating healthy communities through collective action. And so while the framework is new, those strategies are not. And so, this is a different way of doing health extension, but public health professionals have been utilizing these strategies. So these are evidence-based strategies. And our goal here in Florida is to help train extension professionals on how to integrate these strategies into your plan of works, and be able to advance equity throughout the state. And so I'll share a little bit about how we've already started doing that in some of our rural communities with the rural health program. And so as I mentioned before, this is the map of rural counties in Florida. And so if you'll recall the original map of the county health rankings, you'll notice that a lot of those dark areas on the county health rankings map are also the darker counties here, which are our rural counties in this state. So my area of focus is on chronic conditions such as obesity, cardiovascular diseases like hypertension, type 2 diabetes, etc. And so the rural health program focuses primarily on rural and racial, ethnic related disparities in chronic conditions, especially in morbidity and mortality outcomes. So we see in this table here that the percentage of potentially preventable deaths for leading causes of death, like heart disease, cancer, and stroke, are significantly higher in our non-metro counties. So for heart disease, 43% in non-metro counties compared to 28% in our more urban counties. And we see the same sorts of patterns here for cancer and stroke. We also see disparities related to life expectancy. So similar to the ones that we saw, and this is for the US, but similar to the ones that we saw here in Florida, you can see that there are significant differences between non-metro and metro counties overall, between male and females, and also between racial ethnic groups. So with those chronic conditions related to morbidity and mortality rates, obesity is a major driver of these disparities. And so in this table, we see the obesity rates by race and ethnicity among adults in the US, Alabama, Mississippi, and Florida. So in the US, the overall obesity rate is about 42%, and that rate is 42% among non-Hispanic whites and about 50% among non-Hispanic Blacks. You can also see here when we look across the states, and these are just select states that I've worked in related to obesity and chronic conditions. And so in Alabama, that rate is 39%. And you can see here significant difference between non-Hispanic Blacks and non-Hispanic whites. In Mississippi, that overall rate is 40%, with a significant difference between non-Hispanic Blacks and non-Hispanic whites, and the same here is true of Florida. One thing to note, and I did not put a separate slide in here, but these rates are likely underreported. So these are self-reported obesity rates. There was a recent, and it might not be as recent now, I think this was actually a few years ago now, there was an article published by researchers here in Florida using One Florida data. So that One Florida is database that is linked to medical health records. And so we have an actual objective measure of obesity. And so what they found when they compared these rates in Florida here to births rates, which are reported by CDC, the rates were actually about 10 times higher than the self-reported rates here. So obesity in Florida is probably somewhere around 38%, and it's probably somewhere around 46% to 48% for non-Hispanic Blacks in Florida. So what's driving the obesity issue? And we do know that poor nutrition, low levels of physical activity are major behavioral risk factors for obesity. So not considering the social, economic, and environmental ones, the behavioral risk factors, they matter because approximately 75% of Americans do not consume the recommended serving of vegetables, fruit, dairy, and oils. The percentage of adults meeting fruit and vegetable recommendations has actually declined in Florida, going from about 26% in 2007 to about 18% in 2013. Related to physical activity, less than half of Americans engage in the recommended 150 minutes of moderate physical activity a week. And again, in Florida, we've seen more poor health behaviors because the rate of inactive or insufficiently active Floridians increased, going from 53% to 57%. So we're becoming more inactive. So, you know, I've been saying focusing only on health behaviors is not going to be enough. And so what we need is multi-level interventions. And so these multi-level interventions have shown promise for actually being able to impact health outcomes in a positive way. And these are, I did not include this research, but these are just two articles from some obesity prevention projects that I was a part of in Alabama and Mississippi. But these do show promise, targeting multiple levels. And so the Rural Health Project here in Florida, we started, as I mentioned, in 2017 with our first project, and that one ran through 2020. I wouldn't say that it's over, it's just when the funding period ended. But our main objective was to assess the impact of a faith-based nutrition education program related to health behaviors among rural, low income, and racial ethnic minority participants. And so we targeted behaviors and resources like poor dietary practices, physical inactivity, but then we also targeted access to healthy foods and physical activity opportunities. So we used a multi-level approach, as I mentioned. So we had, and a community engaged approach. We engaged extension specialists, our FCS agents and program assistants, our family nutrition program, and master gardeners. We also engaged the community. We trained lay health leaders. We partnered with faith communities and engaged parents and families. And then we focused on changing things at the individual, interpersonal, community, organizational, and environmental level. And I'll share more about that in a couple of slides. We were in 4 counties at that time. And over the course of those 2.5 to 3 years, we engaged a total of 12 faith communities. We trained a total of 24 lay health leaders. We completed 12 cohorts and served over 210 participants. And each of the participants were enrolled in the program for 1 year. So some of the things that outcomes that we targeted here at the individual level, we utilize Faithful Families curriculum. And so that's a health lifestyle curriculum that was developed by North Carolina Extension and North Carolina Department of Health. And the educational curriculum targeted health beliefs, knowledge, the adoption of healthier behavior and healthy lifestyle skills. At the interpersonal level, we engage families and communities in order to promote a culture of health. So we were targeting social support, collective efficacy, and family mealtime. At the community organizational level, we focused on providing those community liaisons. So we trained lay health ambassadors. They assisted our FCS agents with facilitation of the curriculum, but then they were also available within their communities. These were people that came from the communities that we were prioritizing at the time, and they could remain after the educational portion ended. They could still serve as a resource. And we organized them into teams to work on policy systems and environmental changes within their communities. And so we targeted healthy organizational policies and then partnerships to advance health. In terms of the environmental changes, we engaged our family nutrition program here in Florida, master gardeners, and we wanted to increase access to fruits and vegetables and physical activity opportunities. And so here's an example from one of our programs. You can see our FCS agent there. She is hosting a class, and this is one of the activities. They're engaging in physical activity here. So in order to evaluate the program, we used a pre-post test design with no comparison group. Participants completed the pre-test at week 0 and the post-test at week 12. We also conducted key informant interviews. We observed environmental changes, and we focused on having our faith communities create written organizational policy changes. The average age of our participants was 56 years, about 80% were female and 91% were African American. The highest level of education, 33% had a high school diploma or GED, 36% had some college or an associate's degree, and 16% were college graduates. So here's just one example of another activity. So you can see here, they're doing a demonstration to show how much sugar is in a popular, size of a soda. So if you went and got a fountain drink, this is how much sugar you be consuming. So you can see it, you might be able to see expressions here. This look of shock, but it was very helpful for participants to be able to see things like that. And so we did see some changes in health behaviors. You can see here, people were planning more meals by the end of the program. They were eating more meals with families. They were using My Plate. That one changed significantly. They were using nutrition facts on the food labels to make food choices more often. And they were drinking more water, and they were exercising more by the end of the program. In terms of organizational changes, our faith communities were establishing more walking groups, hosting walking challenges. They created exercise programs. In terms of nutrition-related changes, they served fresh fruit instead of pastries between services. They offered water instead of sweetened beverages at church events. They reduced the number of desserts available at church events. So just making small organizational changes. We know that you can't make a lot of changes at once, because people will often reject those changes, but just by encouraging them to make small changes, we hope we were making a difference there. In terms of environmental changes, we did have some faith communities who decided to focus on community gardens. And so here are some photos or images from one of those community gardens. And so that was increasing, access to physical activity opportunities, but also produce. And you can see here, this is outside of the faith community and it's in a residential area. So the faith community members were also able to share some of their produce with members of their community who were not members of their church. So currently we are in Rural Health Project number 2. So we have expanded partnerships. So we started out, as I mentioned, partnering with faith communities, but we have now established UF-IFAS Extension Rural Health Disparities Coalitions in 2 of those counties. And then we have plans to establish coalitions or in counties that already have existing coalitions, then we just partner with those counties. So there are other counties, there are 2 counties where we do have partnerships with coalitions, but we didn't start the partnership or start the coalition ourselves. And then we'll form 2 additional coalitions this year in 2 counties. We've also secured funding from USDA NIFA and the Extension Foundation, where we're focusing on COVID-19 mitigation among rural, racial, ethnic minorities with chronic conditions. And so that started in 2021. And we are testing the effectiveness of multi-level communication and education campaigns to reduce vaccine hesitancy and increase vaccine uptake. And we have 7 counties for that project. We're training extension health navigators. That's a public health practice, and evidence-based public health practice is having some lay health leaders, community health workers, but people from the community who can help reach the community members. And then we're also offering a health disparities training for organizational stakeholders. So in those rural health disparities coalitions, we're going to be offering trainings to we have multi-sector stakeholders at this time. And so we'll be offering training for them and their employees. And just quickly, I wanted to make a plug here. If you are interested in, pursuing or exploring these strategies more, there is an IST that will be hosting some multi-session IST. The first one is February 1st. I'm happy to share more information about that. And then I'm happy to answer any questions you all might have. Thank you so much for your time.
Well, thank you so much, Dr. O'Neal, and for that wonderful presentation. So just as a reminder to everyone, you can type in those questions into the chat box. We'll be monitoring those, and Dr. O'Neal will be happy to take any of those questions. We'll give everyone just a minute to kind of collect your thoughts and type those in. There was one question by Angela Martinez. She asked, can you share the link again? And yes. Okay, yeah. Do you have it, Dr. O'Neal?
I do.
Okay, great. Was that for the extension framework?
That's what I assumed. I think it came in around that time. Yes.
Okay, yeah. All right. And I will also include that in the follow-up email as well. I'll put a link to that. And then Dr. O'Neal put it into the chat. Oh, I think that went into just the host and panelist one. So I will put that into everyone.
Okay.
Yeah.
Sorry about that.
No, that's all right. Yeah. So if anyone else, any other questions or just comments, I'll mute myself and feel free to put those in.
Okay. So what are some of the pitfalls or challenges that you see in using telehealth to address geographic or racial disparities? So I can say, and I'm not exactly sure of the context, but I will say, so for one of the rural health projects that we have currently, it was the call from NIFA asked for it to be a telehealth project. So meaning everything was, anticipated to be done virtually, and we were going to be engaging people that way. One thing that we have found in working with rural communities is that the face-to-face, that interaction and engagement is very important, because otherwise it has been a bit of a challenge, to engage people without having at least some face-to-face contact with them. So I think the barrier there might be, limited engagement with communities. Just in general, in terms of some pitfalls, I really think that overall it can be a positive thing. I'm trying to think of specific challenges, and I really can't come up with anything at this time. I have heard from, individuals within communities that, I'm thinking specifically about the telehealth initiative that we're rolling out for health extension in the 13 rural counties, that it is a positive thing. So that will be through UF Health. I haven't heard any challenges or pitfalls for that just yet. Any other questions or comments? Let's see. Yes, now that's definitely a challenge. As we saw, there was a comment about rural community having issues with internet. So yes, as we saw in the demonstration here in Florida, rural communities do have less access to broadband. So that has been a challenge for that. And I guess I was thinking for the telehealth initiative that we're rolling out through IFAS Extension, that will be at extension offices, so that, basically removes that barrier for broadband internet access.